Hello everyone, my name is TSHERING Bhutia and I'm going to present my unique case on trauma ankle with three views: AP, oblique and lateral. Before I show my radiograph, let me introduce my patient. A 55 years old male patient came with the help of cane in the X-ray department. He has pain on his ankle due to fall on January 2017. This was his third follow-up. He fell down on the train track and hurt his left ankle. His ankle was swollen and has on and off pain for about 4 months. According to doctor's referral, we took three weight-bearing views: AP, oblique and lateral, and let the patient hold his cane on the right side. We took the views. Now I'm going to introduce his trauma ankle radiograph and try to explain how it is slight different from the correct position radiograph of that particular anatomy. So the AP ankle view is my first radiograph. Let's see how and what kind of differences we can see from compared to the correct positioned or normal radiograph. The evaluation criteria states that we must have medial mortise open and the lateral mortise closed. Four-sided collimation include distal 1/3 of the lower leg to the proximal half of the metatarsals, and some superimposition of the distal fibula by the distal tibia and talus. But in the trauma radiograph, we see some differences, such as distal talus is not superimposed to the distal fibula and some soft tissues are not visualized clearly at the same time. If we see this drawing, it will help us understand better. Now, according to the doctor's report, there is a mild comminuted, which means breakage of the bone more than the two fragments at the distal fibula, noted with the butterfly fracture, which is a term usually used in the orthopedic surgery for two oblique fractures located between the distal and the proximal fragments. Now, if we see the slides of a slide for the comparison of the trauma AP view and normal view, how does they look? Next, the lateral view of ankle. As for the radiographic evaluation, our radiograph should visualize like what I have in this drawing of the lateral ankle view. Let's see and compare these two pictures. Criteria says we must have distal fibula completely superimposed to distal tibia, and we have lateral dome and distal fibula superimposed to tibia. Tibiotalar joint space is open, but we have some posterior soft tissue around the calcaneus and missing due to some technique of contrast and density is not adequate to demonstrate those soft tissues. According to doctor's report, diffuse soft tissue swellens mold laterally and anterior and posterior ankle effusions. Also, 1 centimeter rectocalcanean spur means which is caused due to the foot bone is exposed to the constant stress, where the calcium deposits and build up on the back and bottom of the heel bone, where is our Achilles tendon is. Now the last view is oblique. Since the patient has a limited range of motion, we try to rotate as much as the patient could bear. So we will compare that with the accurate position radiograph. Let's see how our radiograph of angle oblique view differs or look different from the radiographic correctly positioned view. The evaluation criteria states 45 medial oblique demonstrate tibio-talar joint open and no or only minimal overlap on the average person. But as we see in this view, it's partially superimposed. 45-degree oblique, the medial mortise is closed and lateral mortise is partially closed. The fibula is seen without tibial superimposition, but our radiograph shows some partial imposition. And we have tarsal sinus demonstrated. The calcaneus is visualized distal to the lateral mortise and fibula. The tibio-talar joint is at the center of the exposure field. The distal fourth of the fibula and tibia, the talus, and surrounding ankle soft tissues are included within the collimated field. The doctor report also suggests swollen is still active before medial joint space of ankle mortise was narrow in the previous report, but now it's grossly normal ankle mortise identified. And that's all for from my today's case. Thank you.